Ji,
We are with you.
we are ready. Can somebody present the case?
Yes, do I need a mic or? So we have a 55-year-old male patient, known case of diabetes, who presented to us with a complaint of abdominal pain and epigastric fullness. This was for 5 months, and his CT scan showed that there was a diffuse swelling of the pancreas that was extending from the head of the pancreas till the body and tail, and there was findings of acute chronic pancreatitis, necrotizing pancreatitis. His amylase was done in January, which was 32.
So why are we doing
So,
EUS?
as I understand, since there is no recent imaging, there is no recent ultrasonography, I think we are doing to see the sequelae of the acute pancreatitis and to find out if there is any pseudopancreatic cyst in the retrogastric bed, or alternatively, if we have a tumor in the pancreas, so maybe something abnormal in the common bile duct which may have led to the development of acute pancreatitis. Dr. Kamran is with me. He has put in the endoscope. He has seen the liver, and right now he's at the where are you? Inferior vena cava? Yes.
Now, sir, I will go clockwise.
Now, okay. Right now, once you have seen the inferior vena cava, you need to go clockwise. Turn right. Turn right. Turn right. Basically, you're looking at the liver. Now, your interest is to go to the aorta. You want to go to the aorta. You don't want to go to the inferior vena cava. Okay, fine. Now, once you've seen the aorta, try to push along the aorta. Gentle push, big wheel slightly away from you, and keep pushing along the aorta. Slight push, gentle push. No, you need to keep the aorta under your vision. Okay, you can see that the blood vessel is coming up. Yeah. But you need to push a little further. Push further. Push. So. कोई बात नहीं, वो हाइट असर नहीं होगा ना जी स्ट्रेट कर लें लेकिन यू नीड टू पुश अलोंग दी हाँ ये ओके नहीं you've gone a bit too further down. You see, you have to find your landmarks. Yes, you have to find your landmarks. Yes, fine. Go ahead. That's fine. This is liver. You should not be injecting any air. In the endoscopic ultrasound, one has to avoid injecting the air. Unless you are in an absolute need of looking at the lumen, one should. No, this is. वो नहीं जा रहा तो that means that there is hiatus hernia. Just go down and then pull back, so that you may be able to see your identifiable structure. Your identifiable structure is obviously the big vessel. You're looking at the liver, fine. You're looking at the various branches of the hepatic vein.
Left hepatic vein, sir.
Okay, left hepatic vein, dividing into medial and lateral segments, fine. But then you need to, because your area of interest is pancreas, you need to turn right to the clockwise side. No, you're injecting air.
आराम से सर वही आ रही है ना, आराम से जा नहीं रही है
दिखाएं.
नीचे मूवमेंट सर सही नहीं कर रही.
Yeah, hydrogen infrastructure, that's right. But then we can see the blood vessels coming up. These are blood vessels coming up. This is the celiac takeoff. Fair enough. And we can generally push along. There you go. Pull back, slightly pull back, slightly pull back. Because we have gone into the, no, you're not supposed to inject the air. Air is to be avoided. Avoid air. Pull back slightly, pull back slightly. Because if you're getting stuck in the head, son, you need to pull back. I've gone into the stomach, right? Now, identify something which is recognizable. Either liver or maybe, yes, fine. Okay, fine. Go ahead. Go ahead. Slide along. If you're feeling that you're stuck in the hiatus, just cross the hiatus, find something which is recognizable, and then according to that recognizable structure, identify the rest of the structures. Okay, fine. You could see that there's liver, fine. Okay, now you can see the liver, right? Now once you've seen the liver, this is a point to turn clockwise. Keep the lumen deflated. Keep turning to the clockwise side. Keep turning. You can see that here you had the hilum of the liver. This is portal vein, right? Keep turning right. Keep turning right. Yes, okay. Now you can see the aorta. Now gently slide along the aorta so that you may be able to find the recognizable structures. Keep pushing along that. Okay, keep pushing along that. Okay. No. नहीं आप तो push देखो चीज़ है कि we have to slide along. I'm trying to push and you're trying to pull me. नहीं देखो. Okay कोई बात हाइट से फंस रहा है ना तो उसमें हाँ आगे जाके ये there you go. ये these are recognizable structures. You can see that there are certain blood vessels. हाँ जी हाँ. Okay. You see that there's white and black shadows, meaning by that fluid is there, necrosis is there. Go according to the anatomy. I've already told you that this is a case of post-pancreatitis and you're expected to see lots of non-anatomical structures.
सर ये जो हाइपरइकोइक नजर आ रही है सर
Yes.
जिसको
Hyperechoic.
shadow भी है ये calcification क्या है
No, this is not calcification. Calcification should be giving bright shadows. This is just a necrotic tissue.
inflamed necrotic
Inflamed, yeah, that's right. Mixed echogenicity structures. And in this, you are not able to find anything recognizable, to be honest. So all you can say is that plenty of changes of post-pancreatitis are visible. There's no clear-cut accumulation of fluid which is well insisted. But do you think that these are anatomical structures, you can link them to any particular structure, any particular thing?
pancreatic वो है ना सर?
नहीं वो तो है, but then you need to find out few recognizable anatomical structures as well. For example, let's suppose kidney, spleen, blood vessel. Are you able to find them? You're not able to find them. Okay, fine. Now you're able to see something. This liver. Okay, fine. Okay. Which structure is that?
This is pulmonary, portal vein.
Portal vein. Okay, fine. Maybe portal vein. Yes. This is portal vein. How about now? Is it portal vein or something else?
Something else, sir. There is no flow in it.
No flow. So what structure can it be at the mid stomach when you are opposing your
Left kidney,
transducer?
sir.
Hmm?
Left kidney.
Kidney. Do you think that the kidney should appear like that?
Yes, sir.
Okay. It's a longitudinal structure coming from the right side of the body. So it has to be something different. किसी रिजर्व वॉशरूम चल रहा है। खालिद है तो खालिद कोई बुला नहीं। Now this structure is coming from the right side. Obviously, what can it be? If it is, there's no flow inside. You can see that there's no flow inside. इसको क्या हुआ है? Okay. Okay, there's no flow inside. So what can it be at this side, at this place? You are right next to the angle of the stomach.
Yes, sir.
What do you think? What can it be? It's a globular. It's a globular structure with anechoic material. There, you can see that there are walls.
Spleen तो नहीं है ना, sir?
नहीं. How can you?
Spleen को
Sorry.
पड़ा होता है, sir.
Where's the cursor? Oh, sorry.
कोई मास तो नहीं है, sir.
नहीं मास तो है ही नहीं यार. देखो ना ये क्या हो सकता है? ये इस तरह की चीज़ जो ग्लोबुलर सी चीज़ है, which is anechoic, has got bright echogenic walls. It has to be gallbladder. This is gallbladder, right? This is distended gallbladder. भाईजान, मैं जरा वॉशरूम जाना है.
ठीक
हाँ,
है,
ये
मैं ले लेता हूँ।
you're on. Most pancreatitis है.
मैं देख रहा था और पैंक्रियाटिक नेक्रोसिस है वो सारा।
Sir.
यार वो मुझे कहूँ क्या हुआ? ठीक है। हाँ वो उसमें कई दफ़ा फंस जाता है। हाँ तो उसमें यही होता है तरीका कि आपने हाइपोथर्मिया से बच के आगे जाना है, ठीक है, और फिर आपने सीधा पैंक्रियास पे जाना है, क्योंकि उसमें आप फॉलो नहीं कर सकते एओर्टा से, क्योंकि अगर आप एओर्टा से फॉलो करना चाहेंगे आप दोबारा फंस जाएंगे।
हाँ, फंस रहा है, सर. 2 दफ़ा फंस रहा है.
हाँ मैं अभी हाँ नज़र आया तो फिर उसके बाद ठीक है बिल्कुल क्लॉकवाइज रहते जाए थोड़ा सा ना स्कोप को ऐसे करें थोड़ा सा आप पीछे ठीक है तो उसका ये फ़ायदा होगा कि बिल्कुल ठीक है तो यहाँ से हमने लिवर को छोड़ के ना ठीक है आप ऐसा करोगे कि आप सीधा जो है ना एओर्डा पे चले जाओ ठीक है तो आप चलो अगर लिवर देखे ना तो आप देख लो ठीक है कोई बात नहीं ठीक है चलते जाओ ठीक है अब जो है ना आपका ये हो रहा है कि आपका व्हील जो है ना टू मच टूवर्ड्स यू वो उसकी शेप से ही मुझे पता चल रहा है कि आपका व्हील जो है ना इज़ नॉट राइट पोजीशन ठीक है तो पुल करके बिग व्हील टूवर्ड्स यू अ लिटिल बिट नाउ ठीक है रोटेट टू द राइट थोड़ा सा पुल करें आप ठीक है रोटेट कर देंगे राइट की तरफ राइट ठीक है ठीक है एओर्डा आ गया ना जब ठीक है तो यहाँ से अब जेंटली एडवांस करना है आपने ठीक है
इधर जोर मांग रहा है ना सर देखिए काफ़ी जोर मांग रहा है
हाँ फंस रहा है ना तो फिर आपको जो है ना वो
अवे करूँ
हाँ रिलीज कर दो ठीक है अवे कर दो बिल्कुल सो वन थिंग इज इट हैपनिंग इट्स कैन यू हियर मी साद भाई
गाड़ी हेड में फंस रहा है सर
Khalid, hear you and see you.
Okay, so what's happening here is Kamran, when he found the liver, he went to the aorta, and when he was following the aorta, he could not move the scope, could not advance the scope. And when that happens, that your scope is stuck onto the wall, and usually happens in case of hiatal hernia. So you do not want to push through that. You can see that here. There is a huge hiatal hernia.
Big hiatal hernia.
Big hiatal hernia. So in these cases, what you really have to do is you have to let the big wheel go away, get off the wall, and instead of following it from aorta downward, you have to follow from pancreas backwards. So you really go straight to the pancreas instead of following the anatomical marks.
Okay.
And the way you do that,
I think we're still not gone beyond.
yeah. So here what's happening is, it's a huge hiatal hernia. I'm going to get through that first. So right here, this is the area where I need to be. And from here, I'll try to find the pancreas. You see that all that inflammation there?
Khalid,
Right there. So what I did is I went straight to the mid-body of the stomach, really. And then from there, I was in this position. You see that right there, went to the mid-body, suction, scope is straight, rotating to the right until I find a familiar structure which is the pancreas right here. There's really, I don't see any viable tissue here. This looks like, इसका arrow नहीं काम करता?
cursor काम करना चाहिए.
Cursor काम नहीं कर रहा?
नेक्रोटिक टिश्यू है सर
हाँ वही बिल्कुल.
I'll show it. You go ahead.
So here, you see that all that necrotic tissue right
Yes,
in the
we can.
center, irregular. There's a hyperechogenic and echogenicity. And as
So you
said
have-
earlier, the history is important too. And you see all this is necrosis there really.
All shades of gray.
All shapes.
And white.
So here it's going to be really even like right there, that's supposed to be a pancreas, but it's all necrotic and dead tissue. What I'm doing is I'm following it back, pulling the scope back, pulling the scope back to go towards the tail of the pancreas, which appears to be right in this area, because I don't see any further pancreas. It's all necrotic pancreatic tissue there. Right? And you see the aorta. नहीं काम कर रहा अभी. You
We
see
can
that?
also see some lymph nodes there which look benign.
Could be inflammatory. You see the aorta right there?
Yeah.
And you see on the left side of the screen all the pancreatic necrosis. Okay. Right there. So I know that there is no more pancreas beyond that,
Yeah.
because I can get to the, I could see the aorta from there. Right here at the bottom you see the aorta. And we have the pancreas in view as well. It's a too much shadowing that one. This is
Duct
all.
तो मुझे नजर नहीं आ रही.
जी?
कहाँ पे? Could you see the pancreatic duct at all?
Not really. It's all.
And can
There,
you
there may be. There
CBD
is a duct right
there is
there.
right
You see
Doppler
that
चलाएं.
right above the
Doppler
right
चलाएं.
where that hyperechogenic.
Can we have the Doppler on, please?
Oh yeah. Right above, you see in certain areas, right above the echogenic area, it comes right there, right where the echogenic area is. Where it starts from the top, that's a part of the duct, and it's going to the right now, going to the left, right above that, but then I lose, it kind of ends up into this anechoic area. I don't see the duct beyond that.
This echogenic area is all inflammation.
All necrosis. Necrosis is sort of inflammation. Okay. And there is a lot of peripancreatic necrosis, looks like as well. Pancreas in the center, and the area around that is also irregular. Right at the, can't even make it work. It's good, Jan. हाँ फ्लो से फ़ायदा कोई नहीं है ना मेरा भाई. हाँ क्या करें. And look at that area, even in the antrum, lot of inflammation there. And can you see the bile duct right there? Salbhai, I can't point to it, but that's a gallbladder up there and the bile duct right there. Anybody there to point to it?
Hello. No, Dr. Saad is not here, Dr. Khalid. I think
Okay.
this is. Yeah.
Is the lymph node
Like
This is inflamed.
no.
Bile
That
duct?
bile duct wall है वो.
नहीं सर ये बाकी जो
Baki is all inflammation. Okay. What happened? How did it came? अच्छा क्या किया आपने? धक्का मारे. So it came. गैस भाई कह रहे हैं कि धक्का मारे तो ठीक हो गया. So here you see the bile duct
Yes.
right there, and if you look at the bile duct actually, bile duct does have 3 walls to it. Okay, wall layers I should say. So bile duct is kind of very inflamed there. You see the first hyperechogenic, then black, and then white. So it has 3 layers really. It does not have 4 layers like any luminal wall. But this does, it looks, they are so indistinct, they are so distinct from each other. So this is not really a tumorous thickness. It's because of the inflammation and pancreatitis. That's what that thickness of the wall is. So here, you see a nice right there all the way, and going down. That's a gallbladder there. Okay. Gallbladder there. That's a bile duct right there. Now it's a less thick right there. I mean, it's more dilated, but wall is less prominent there. But here it becomes quite prominent in that area, where obviously the all the inflammation in the head of the pancreas. At least I don't see a stone in there. Yeah, but there's a lot of inflammation right there. It's all necrosis. So I don't know what the cause of it. Possibly could be he might have passed a gallstone. But I don't see it. You see, I'm kind of scanning the whole gallbladder and nothing there. Huh. Let's see. Aorta right there. You can see the uncinate is here. You see the pancreatic duct and the bile duct right there. Bile duct is still quite thick right there. Like the whole distal bile duct wall is thick. And PD is right here, but not very prominent. And all the inflammation, foci strands. But majority of that necrosis is in the pancreatic neck and body and rest of the pancreas. You see all that? It's all necrosed. चलो आ जाओ आप करो सर डुआर्नम का दिखाओ मुझे.
Khalid bhai, would you say this is walled off necrosis or not walled off necrosis?
Oh, I don't see any wall around that on any angle. But the best way to take a look for that is either MRI, or likely MRI, because sometimes the distal part you can't see, but I do not see any wall around that. It's a very irregular, it's in different stages. There is a little bit anechoic areas, but majority of it is just a thick necrotic tissue without any sort of wall.
Yeah, Dr. Khalid. So CT scan, MRI would be preferable as compared to CT scan. To look.
MRI is better to take a look at the wall, yes, and the consistency of necrosis and the, how much necrotic area is, how much fluid is in that.
Okay.
So MRI is better. Sometimes CT is not very helpful in that regard.
Right. Thank you.
किधर गए हमारे रेडियोलॉजिस्ट वही कुछ बोल दो. We need comments from radiologist about that.
Regarding what she's asking?
About what would be the best, MRI, CT scan, looking for pancreatic necrosis, and ratio of fluid versus necrosis itself, the wall around the necrosis, all that stuff.
Yeah, she agreed with you.
हाँ जी, ये gall bladder. So जब आपको gall bladder नजर आ रहा है, that means you are too superficial. You need to go a little deeper in there. You are sitting at the pylori, right there. Good. Up there, no, not too much. Take a look at the EUS image, right? You see the bile duct right on the top, correct? So pay attention to that. Now big wheel towards you a little bit. Okay, big wheel towards you, big wheel towards you, a little bit. That's it. Now rotate the scope anti-clockwise. Keep going, keep going. Pull the scope back a little bit. Big wheel towards you. Big wheel towards you first, please. Big wheel towards you. You're not moving the big wheel towards you. All the way? Okay. So then move the scope back. Okay, good. Now, yeah, counterclockwise, I think we're losing it right in that area. Now rotate to the clockwise. Big wheel towards you. Good. So then we can push the scope in a little bit. That would help. Now release the wheel after pushing the scope in because you're compressing on the bile duct. You can see? Good. अब आपकी जो wall है, that's falling down here. So you are right close to the ampulla, which is good. Okay. नहीं नज़र तो नहीं आ रही है इसमें। वो सारा इधर है प्रॉबली पीडी ये है, लेकिन शेडोइंग वो एयर शेडोइंग बहुत है ना। राइट देयर, ये यहाँ पे पीडी आई थी। तो अब अगर रोटेट टू द लेफ्ट अ लिटिल बिट एंटी क्लॉकवाइज चलते जाए, बिग व्हील टुवर्ड्स यू, big wheel towards you, good, right there, you see that, now it's bad, ठीक है ना, यहाँ पे आपको नज़र आ गई ना, okay? अब एओर्डा यहाँ पे आप D2 में पहुँच गए हो, ठीक है, तो यहाँ पे वो बाइल डक्ट है और पेंकेटिक डक्ट अंडरनीथ, ठीक है, अब तो ये IVC आ गया आपका, ठीक है, और आप थोड़ा सा इसको पुल करो स्कोप को बाहर, keep pulling, keep rotating to the right, रिलीज करते जाएं व्हील को and keep pulling back, थोड़ा सा रिलीज, keep pulling the scope out, good job, excellent, keep coming, ठीक कर रहे हो, ये देख रहे हैं ना बायोडेक्ट, नाइस, तो बाकी सारा पैंक्रियाज इधर है, it looks reasonable here, you see inflammation in the pancreas, foci strands, थोड़े से lobules हैं, borders इसके ये पेंकेटिक डक्ट है,
हेड है ना सर,
हाँ बिल्कुल है,
ऊपर जो है तो
वो
जो जन वाला ऊपर उससे ऊपर,
हाँ नहीं ये बाइल डक्ट है, ठीक है, ये पेंकेटिक डक्ट है, ये पूरा हेड है उसका, ठीक है, और अगर आप वॉल को देखो ना तो उसमें बहुत सारा अडीमा है, ठीक है, वॉल लेयर्स डिस्टिंक्ट नहीं है, तो ये सारा इन्फ्लेमेशन की वजह से, यानी कि स्ट्रक्चर्स आपको पता है कि आप सही जगह पे हो, बट दे आर नॉट डिस्टिंक्ट बिकॉज इट्स टू मच इन्फ्लेमेशन देयर, ठीक है, तो आप यहाँ पे अब हमने ना सिर्फ you're gonna as soon as you start moving back तो आपका बाइल डक्ट लूज हो जाएगी, मेन चीज़ है कि आपने पैंक्रियाज पे ध्यान रखना है, ठीक है, अब आपका नेक्रोसिस वाला एरिया शुरू हो रहा है यहाँ से, ये देख रहे हैं,
मैं थोड़ा सा पुल करूँ,
हाँ थोड़ा सा पुल करो और रोटेट करो राइट या लेफ्ट की तरफ, राइट, ब्यूटीफुल, राइट की तरफ चलते जाओ, राइट की तरफ जाओ, और ये अब आपका नेक्रोटिक एरिया शुरू हो गया, ठीक है, आपका
नीचे सर जो है
ये वेसल्स हैं, मेसेंटेरिक वेसल्स हैं, ठीक है, आते जाओ नीचे, आते जाओ, गुड, आते जाओ, रिलीज करो, अब थोड़ा सा जब इसने बाहर निकलना है ना उन्हें डुआर्नम से, तो इसका ना फॉल अ लिटिल बिट, रिलीज द व्यू देयर, ठीक है, अब जो है ना आप थोड़ा सा वापस चले जाओ, देख रहे, ठीक है, और फिर अब आप दोबारा पेंकेटिक बॉडी पे आ गए, ठीक है, तो इसको थोड़ा सा और, यानी कि आपको एडजस्ट करते रहना, बिग व्हील टुवर्ड्स यू अकॉर्डिंग टू द पोजीशन कि कहाँ पे हो आपको, ठीक है, गुड, चलो ठीक है, वो हो गया, तो
अब अपना आप बता रहे थे आउट ऑफ प्रिलिमिनरी व्यू इसोफेगस में 30 सेंटीमीटर तक,
हाँ यूजुअली ना स्कोप को ऐसे रखें, ठीक है, ऐसे, और चलते हैं यूजुअली ना स्लो, जब 35 पे पहुंचे तो स्लो हो जाए, बिग व्हील अ लिटिल बिट टुवर्ड्स यू, ठीक है, स्कोप स्ट्रेट, तो देखा आपका वो आ गया, लेफ्ट एट्रियम आ गया, रोटेट करें राइट पे, ठीक है, लेफ्ट एट्रियम आ गया, पल्मोनरी आर्टरी आ गया, ठीक है, रोटेट अ लिटिल बिट टू द लेफ्ट, release the wheel, little bit, थोड़ा सा बिग व्हील अवे फ्रॉम बिग व्हील, ये ठीक है, आपका व्हील बहुत ज़्यादा ऊपर है, तो ना पल्मोनरी आर्टरी, ठीक है, लेफ्ट एट्रियम और AP विंडो, ये आपको लिफ्ट नोड भी नज़र आ रहा है वहाँ पे, ठीक है, और ये एओर्टा है यहाँ पे, ठीक है, अब यहाँ से आप रोटेट करें स्कोप को, सिर्फ रोटेट करते जाए नीचे, राइट देयर, एओर्टा आ गया ना, ठीक है, आप स्कोप को पुल करना शुरू कर दें, पुल करना, अब यहाँ पे रुक जाएं जहाँ पे एओर्टिक आर्च ख़त्म होने वाली, ठीक है, तो उसको जो है ना बिग व्हील लिटिल बिट टुवर्ड्स यू, ठीक है, बस इतना, ठीक है, थोड़ा सा इसको पुश करें स्कोप को और रोटेट करें राइट की तरफ, देख पल्मोनरी आर्टरी यहाँ पे आ गई, एओर्टा वहाँ पे, AP विंडो वहाँ पे, थोड़ा सा आप इसको एडजस्ट कर सकते हैं, रोटेट राइट एंड लेफ्ट, ठीक है, चलो गुड, चलो निकालो, गुड जॉब, सारा पेंकेटिक नेक्रोसिस है, हाँ वो दिखा दें, मैं वो जो है ना उधर आप उनको लगा दें और फिर मैं जाकर उनको एक्सप्लेन कर देता हूँ।
है तो we have to change the position.
वो है ना अगले
Saad, can you hear us?